Good day everyone, I'm John, moderator for this webinar. Welcome everyone for today's webinar, CMS Hospital Conditions of Participation 2022, Surgery PACU and Anesthesia Standard. I would now like to introduce our presenter for today, Darlene Evans. Darlene Evans, MSN RN CPHQ, is a nurse consultant for Nash Healthcare Consulting. Darlene brings 25 years of experience in the healthcare industry, specializing in clinical and regulatory operation management and accreditation readiness and response. I would now like to hand over the one of the best speaker of NASH, Darlene Evans. Over to you, Darlene.
Hi everybody, and thank you for joining us. We'll start moving through. This again focuses on CMS hospitals' condition of participations, and ending 2022, the new standards for all of the accreditation and regulatory processes will go into effect 2023. So we always like to say that depending on your hospital type, where you're located, certainly the state you're within, you want to be mindful of any pending changes that might be reflected for your state become effective January 2023. So this particular focus is on surgery, PACU, and anesthesia standards, and we'll go ahead and get started. Just for those on the call that might be new to your roles, one of the things we like to point out is these particular requirements are federal and state mandates from CMS. One of the things we always remind you of too, how do you keep up with the CMS standards, conditions for participation? They're quite voluminous. So the initial point of focus was in 1986, and they're divided. If you're also duly accredited by Joint Commission, CMS uses the term tags or tag numbers. So predominantly on your screen you see A for hospitals. We call that Manual A or Appendix A for the Medicare State Operations Manual. If you're critical access, then of course we'll show you those. In that CMS access, regardless, it gives you other types of resources, again, for your support for your care treatment service within your organization. So in this particular focus, the CMS manual survey memos issued. The other thing they do is quite often put I'm going to say tips of the trade. It's an open book. They give you the expectation for practice. And so a lot of times based on the tags and what they expect in your delivery of care, improving safe quality care. So our focus is looking at the CMS memo that was released on safe injection practices, single dose, and infection control breaches relative to that. Quite an extensive topic. The national standards are imperative. And again, anything that's coming out of CMS, remember, those are federal and state guidelines, so it is imperative that those be followed. And then discarding them appropriately. So again, your state may have regulations around this, but appropriately in this country, following under the CDC guidelines for discarding, whether it's red waste, considered white trash or white general waste, and or then if it's hazardous materials or hazardous medications, quite often in yellow. Don't let the colors fool you. You want to follow those guidelines appropriately. So then we transition to the Institute for Safe Medication Practices and Guidelines, the ISMP, for IV push medication. And this is the similar to the same medication practice expectations, but there are some specific care and safety aspects about this information. You can again find it on the website at ismp.org. We've provided that information for you. And it does add the additional practice expectations and safety tips for you. There are many worksheets that some of the best practice organizations use or guide. There certainly are for CMS. So now you get CDC on safe injection practices, same thing. And again, more specific in regards to getting down to the granularity of why we have these practices. So lots of, again, resources there, those we've just talked about. Safe opioid use, big topic again. Want to talk a little bit about deficiency data. You see again from those deficiencies where based on each tag they're calculated. Joint Commission, HVAP, and all the organizations do this to know where the highest citations are. So looking at the COP section for surgery, PACU, and anesthesia. For surgery proper, surgical services, procedural areas, perioperative arenas, you want to again utilize as many evidence-based resources as possible. So circulating REM, surgical privileges. A lot of times we're talking about your advanced providers, so APRNs, PAs, and/or anybody on the medical staff with surgical and clinical privileges as deemed designated by the organization and medical executive team. So we've given you again some tool kits here for keeping your environment in the procedure and perioperative and operative suites safe, what's expected, preventing OR fires. This is actually still tragic when it happens, but it still does happen, which means we have to continue to be vigilant to prevent them. All right, and a lot of these now, if you'll see, so again, even if you're only CMS accredited or surveyed, if you will, again, use these resources that are available to you. So you don't have to necessarily be duly accredited by Joint Commission or DMV, but their information and packets and resources are available to you as well. Documented appropriately in the record as according to scope of practice and roles and responsibilities, making sure that it's complete. Again, what's appropriate in a full H&P versus an assessment. The OR register, this is imperative, whether still manual or electronic. There are requirements, and the reason for this is quite often for the devices we use or implantables, they have to be tracked accordingly, right? And again, with and in concert with anesthesia. So with and separate from. So anesthesia itself must be provided in a well-organized manner under qualified physicians, an MD or a DO only, who can administer, and again, we've said this, your medical staff provider or advanced provider under the designation of a scope of practice. And then based on those provisions, if they're approved or not. So we've talked about this and that they're reevaluated. So we said at minimum every 2 years in that credentialing and privileging process. So critical access, I've referenced critical access hospitals, so I'm going to move very quickly through this. And this is actually where up until we've now finished talking, all of these are now available just as resources to you. But whether you're acute care hospital, critical access hospital or less, then you want to be mindful again of what we've talked about. So this just summarizes again. So the American Society of Anesthesiologists, just as much as all the other service guidelines are there, as we've said, we will say this is most important because no matter who's doing that anesthesia review, whether it's that surgeon or CRNA under the surgeon or an anesthesiologist, they do use the ASA physical status classification system for identifying the appropriate care process for that patient, what level of risk they are, what needs to be determined that we've talked about, but this gives you more specifics. And then these are discussions that, again, are case studies. It gives you, I'm going to say, points of challenge for you and that you want to look at and discuss with your staff. Because it is important. I thank you for your time today. It's always our pleasure to help you in any capacity, be it by education services or on-site visitation. All right. Thank you so much.